Welcome back to the Deep Dive. Today we are wrestling with a question that really lies at the heart of the mental health journey for millions. Can mental illness actually be cured? It's such a natural question, isn't it? It comes from that hope for, a final solution, like a surgery or a magic pill that just makes it all disappear.
Right. We all want that definitive fix.
But our sources suggest that looking for a simple cure often, well, as one expert put it, it fundamentally misunderstands and, frankly, undermines the inherent complexity of mental health disorders.
That's really the crucial starting point, I think. Based on, the vast amount of clinical evidence and research we've looked at, the clear answer for most persistent mental health disorders is no.
No cure.
No, not in the traditional medical sense. The vast majority are chronic conditions, lifelong conditions. They involve these fluctuating brain chemistries, genetics, environmental factors interacting.
So complex.
Exactly. And that means they need ongoing, sophisticated management, much like, other chronic physical conditions. Think type 1 diabetes or high blood pressure.
Okay, so our mission today then is to shift that thinking. If cure isn't the end goal, what is? We're going to take a deep dive into why these conditions are chronic, how they even start those complex roots, how we might recognize the signs in ourselves or others.
And really importantly,
what does recovery actually look like?
Yeah.
That sustained, fulfilling life, even with the condition, especially considering different disorders have such different paths over time.
Yes. We really want to replace that idea of elimination with the concept of recovery.
Recovery, not elimination.
Recovery. It's not about being disease-free. It's about finding stability, getting back function, significantly improving your quality of life, even if the underlying susceptibility is still there.
That makes sense.
Understanding that stability, that management is the new standard.
Yeah.
Honestly, that's the most empowering knowledge you can have.
Okay, let's really unpack this then. In medicine, that word cure, it sets a very high bar, doesn't it?
Extremely high, yeah.
So what exactly does that clinical definition mean?
Yeah.
And why doesn't it quite fit when we're talking about the mind?
Well, medically speaking, a cure means a total, irreversible reversal of the illness.
Total and irreversible.
It means the actual disease mechanism is gone. All evidence of it vanishes, and crucially, it won't come back.
Won't come back.
Think about curing, say, bacterial pneumonia with antibiotics.
Right, you take the course, it's gone.
Or setting a broken leg, it heals. The specific problem is fully resolved. You're back to your pre-illness state, and you don't have the risk of that particular break just recurring on its own.
Got it.
Right.
But the mind, the brain, that's not just one broken bone, is it? It's this whole universe of chemistry, electricity, personality, experiences.
Exactly, all interacting constantly with everything around us. It's a much messier system, you could say.
Yeah, messy feels right.
Yeah.
Harder to just sterilize of a condition.
It is, and that's why the analogy you often see, and it's a good one, compares chronic mental health conditions to something like high blood pressure.
Ah, okay, like the example you mentioned earlier.
Yeah, so imagine someone has high blood pressure. They make huge lifestyle changes, lose weight, exercise consistently. Their blood pressure returns to a healthy range without needing medication.
Fantastic result.
Absolutely fantastic. They've resolved the dangerous reading, but did they cure the underlying tendency?
Probably not, right? If they stop the healthy habit.
Exactly. They didn't eliminate the underlying biological or maybe genetic susceptibility that put them at risk initially. If they go back to old habits, the pressure almost certainly climbs again.
So they're always susceptible.
They are perpetually susceptible. And that chronic susceptibility, that's the key difference between resolving symptoms and a true cure. And it's why mental health professionals use the language of remission and relapse.
Okay, remission and relapse. So remissions are like the blood pressure being normal. Okay, symptoms have faded, maybe for weeks, months, years.
Great.
And relapse is when they return. But what's the actual practical benefit for someone living with this to think in terms of remission instead of cure? Why is that better?
It creates vital preparedness, both psychologically and behaviorally.
How so?
Well, if you believe you're cured, what might you do?
Stop the treatment, stop therapy, maybe stop taking meds.
Precisely. You might abandon the very things keeping you stable. You might ignore the early warning signs of things slipping.
And then you'd be completely blindsided if it came back.
Utterly blindsided. And that relapse might be harder to treat, require more intensive intervention. But if you accept You're in remission.
You stay vigilant.
You stay vigilant. You keep checking your mental health blood pressure, so to speak. You stay connected to support, stick to your routines, and you recognize those subtle early shifts much faster.
Allowing you to jump on it quickly.
Yes. Swift intervention can often prevent a full-blown crisis. So remission isn't passive freedom from disease. It's an active state of health maintenance.
That really does reframe the goal. Okay, so if the goal is management, let's look at the problem itself. Why do these conditions start? Why do people get them? And this is where it gets really interesting, because the sources are clear. It's almost never just one thing.
No, never that simple. It's this complex, multi-layered web of risk factors. We tend to look at it in sort of three interacting spheres.
Okay.
It's the constant interplay between these spheres that really explains why these conditions are often chronic and so complex.
Let's start with the first sphere, this sort of biological foundation, the hard wiring.
Exactly, biology and genetics. This often involves inherited genes that increase vulnerability, but it's not straightforward like inheriting eye color.
They're complex than that.
Much more. We're talking epigenetics too, where environmental factors can actually turn certain genes on or off, dictating whether that inherited risk even shows up.
Wow.
And then, crucially, there are disruptions in brain chemistry. Imbalances in neurotransmitters, those chemical messengers like serotonin for mood, dopamine for reward and motivation.
And psychosis sometimes.
And psychosis in some conditions, yes. An imbalance there fundamentally changes how the brain talks to itself.
It sounds like it's not just a head problem, though. You mentioned the body, the gut even.
You've hit on a really fascinating and rapidly growing area of research, the gut-brain axis.
Gut-brain axis, okay.
We're learning just how deeply brain function is connected to the health of our gut microbiome, other organ systems too.
How does that connection work?
Well, there's the vagus nerve, like a superhighway connecting the gut and brain. But even more striking, something like 90% of the body's serotonin, 90% is made in the gut. So if your gut environment is off due to stress, poor diet, inflammation that can directly mess with the production of these crucial brain chemicals.
Leading to mood or thinking problems.
Potentially, yes. It shows it's truly a whole body vulnerability.
Okay, so that's the biological base. What's the second sphere? How do outside pressures play in?
That's the environment and life experiences sphere. You know the saying, genetics loads the gun, environment pulls the trigger?
Yeah, I've heard that.
It applies here. Stressful experiences, especially really difficult things in early childhood trauma, abuse, neglect, can literally shape the developing brain architecture, increasing risk for life.
And it's not just childhood trauma.
No. Even exposure to toxins, certain viruses, or substances before birth can create vulnerabilities. And then in adult life, major stressors, losing a loved one, job loss, chronic high pressure can easily push someone who's biologically susceptible over the edge into an episode.
Right. And the third piece is other health issues.
Yes. Physical health comorbidity. This is a huge factor. We see much higher rates of mental health problems in people dealing with chronic pain, cancer, heart disease, inflammatory conditions.
Makes sense. That must be incredibly stressful.
It is. Also, a traumatic brain injury, a TBI, significantly bumps up the risk for later depression, anxiety, even personality changes. And finally, social factors, feeling isolated, chronic loneliness, lack of support, they amplify all these other risks.
Connection is protective.
Hugely protective. Its absence is a major risk factor.
I want to zoom in on one specific group the sources mentioned, late life depression.
Yeah.
How does that often show up, and why does it get missed so much in older adults?
Oh, yes. It's a massive challenge. Because depression in seniors often doesn't look like typical sadness or crying spells.
How does it look then?
It frequently gets masked by or mistaken for just normal aging, or even early dementia. Instead of saying, I feel hopeless, an older adult might present mainly with physical complaints.
Like what?
Unexplained aches and pains, really profound fatigue, loss of appetite, maybe significant memory problems, or trouble concentrating, sometimes called pseudo-dementia.
So the family thinks, oh, it's just arthritis, or mom's just getting older, but it's actually major depression.
Exactly, manifesting physically and cognitively. And the unique risk factors for this age group contribute to this camouflage.
Such as?
Well, they're often dealing with multiple losses, grief, loss of independence, friends passing away. Social isolation after retirement is common. There can be vascular changes in the brain that predispose them. And medications are a big one. Many older adults are on multiple drugs for various chronic illnesses, and some of those medications can have side effects that mimic or even cause depression.
That's tricky.
Very tricky. And the stats are worrying about 7% of the elderly worldwide suffer from depression. Getting it recognized is crucial, partly because this group also has a higher risk of suicide if untreated.
Okay, so if these conditions are chronic, sometimes masked, how does someone actually recognize they might need help? What's the sort of personal checklist people should keep in mind? How do you tell normal ups and downs from something more serious?
The key word is disruption. Mental disorders disrupt your ability to function in major areas of your life: work, relationships, school, even basic self-care.
So it's not just feeling down for a day.
No. It's when a pattern of thinking, feeling, or behaving consistently and significantly deviates from your usual self, your usual character, and it's causing problems. That's when you should really consider seeking help.
Can we list some specific red flags, things people should watch out for?
Sure. We look for sustained shifts, like feeling excessive worry or dread way out of proportion. That gets in the way of daily tasks.
Okay.
Changes in those fundamental biological drives, sleeping way too much or way too little, big changes in appetite leading to weight gain or loss, a noticeable drop or change in sex drive.
Things that are usually stable.
Right. Also, severe mood swings that feel out of control. A real loss of interest or pleasure in activities you normally love, that's called anhedonia.
Anhedonia, got it.
Or just a significant drop in performance at work or school that you can't explain. And then, of course, in more severe cases, any difficulty telling what's real from what's not, hallucinations, delusions, those need immediate attention.
But it's important to say, you don't need to be hallucinating to need help. And if it's disrupting your life, that's enough.
Absolutely. That disruption is the key indicator. The first step is usually talking to a primary care provider. If they suspect something, the formal diagnosis process starts.
And that involves
Usually, a comprehensive psychological evaluation. This is done by a specialist, a psychiatrist, psychologist, or maybe a licensed clinical social worker. They assess thoughts, feelings, behavior patterns using structured approaches.
where do those structured criteria come from? Is there a standard?
Yes, there is. Clinicians use the Diagnostic and Statistical Manual of Mental Disorders, the DSM-5.
The DSM-5, okay.
It provides standardized criteria, specific symptom lists, duration requirements to make sure diagnoses are consistent. So when one clinician says major depressive disorder, another knows exactly what that means.
That consistency seems really important. What about ruling out physical problems? You mentioned hypothyroidism earlier.
That's absolutely critical, the ruling out phase. It's mandatory, really, because so many physical conditions can perfectly mimic mental illness symptoms.
Like thyroid issues.
Thyroid issues are a classic example. Hypothyroidism looks like depression, fatigue, weight gain. Hyperthyroidism can look like severe anxiety or even mania. Neurological problems, vitamin deficiencies, they can all cause cognitive or mood symptoms.
So what does the ruling out involve?
Usually a physical exam, comprehensive blood work, sometimes brain imaging like an MRI or CT scan. The goal is to exclude any physiological cause or even substance use that might be driving the symptoms you're seeing.
Okay, and during this whole diagnosis phase, what's the most important thing the listener, the patient, needs to do to help get the right plan?
Complete honesty, painful honesty sometimes.
Well, painful.
Because you need to be open about everything. The full history of symptoms, any substance use, past traumas, family history of mental illness. Hiding things, minimizing things, it leads to an inaccurate diagnosis.
And the wrong treatment plan.
Exactly. And specifically, you need to be clear about whether your symptoms feel chronic, like they're always there to some degree, or episodic, coming and going, maybe with clear triggers. That detail is vital for planning management. If the diagnosis isn't right, the management plan designed to get you into remission. It's doomed from the start.
Okay, so we've established cure isn't the goal. We're aiming for management, remission, recovery. How do we actually do that? How do we solve the daily disruption? It sounds like it boils down to personalized, long-term management plans.
That's precisely it. It's about combining evidence-based strategies tailored very specifically to the individual, their disorder, its severity, their life context, their goals. No two plans are identical.
Let's break down the main tools. Psychotherapy, talk therapy, seems like a cornerstone.
It often is. Psychotherapy is essential because it gives you the skills to understand and manage your thoughts, feelings, and behaviors. And there are many effective types.
Like CBT.
Cognitive behavioral therapy, CBT, is a big one. It helps you identify and change those negative or unhelpful thought patterns that fuel difficult emotions and actions. There's also interpersonal therapy, IPT, which focuses on relationships and social roles, since relationship stress is often a major trigger.
And therapy isn't always one-on-one.
No, it can be individual, which is very common, but group therapy can be incredibly powerful for sharing experiences and reducing isolation. Family therapy is also crucial sometimes, especially for younger individuals or when family dynamics play a big role.
Okay, then there are medications. This seems to be an area with a lot of misunderstanding. People sometimes see them as a magic bullet, or conversely, something to avoid at all costs.
Right. Medications are powerful tools, but they're tools for symptom improvement, not cure. Their main role is often to stabilize brain chemistry enough so that therapy and lifestyle changes can really take root and be effective.
How do they work, generally?
They work to rebalance those neurotransmitters we talked about. We classify them based on what they target. Antidepressants like SSRIs or SNRIs generally increase the availability of serotonin or norepinephrine to help lift mood and often reduce anxiety.
And they're not just for depression.
No, many are very effective for anxiety disorders too. Then you have mood-stabilizing medications, things like lithium or certain drugs also used for epilepsy. These are absolutely essential for conditions like bipolar disorder.
Why essential for bipolar?
Because the primary goal there is preventing those extreme mood swings, the dangerous highs of mania, and the debilitating lows of depression. Stabilizers help keep things on a more even keel.
Got it. What about those fast-acting anti-anxiety meds and the stronger ones?
Right. So fast-acting anti-anxiety medications like benzodiazepines, Xanax, Valium, Ativan are common names. They provide quick relief in a crisis. But
There's a but.
there's a big but. They carry a significant risk of dependence and withdrawal. So they're usually just for short-term acute situations. For ongoing anxiety, we prefer treatments like certain antidepressants or therapy.
Okay, and antipsychotics.
Antipsychotic medications are primarily used for disorders involving psychosis, like schizophrenia, but they can also be used sometimes alongside other medications, maybe to boost antidepressants in severe depression or help manage mania or depression in bipolar disorder if other meds aren't fully working.
So the goal with all meds is symptom management, getting things stable enough to function.
Exactly. Bringing symptoms down to a manageable level so the person can engage in therapy, work, relationships, live their life.
What happens when medication and therapy just aren't enough? The sources mention brain stimulation treatments. That sounds pretty intense.
They are generally reserved for what we call treatment-resistant cases, meaning standard approaches haven't brought significant relief. These treatments work by directly modulating brain activity, kind of bypassing the usual chemical routes.
Can you walk us through the main types? Like ECT, that one has a bit of a history, right?
It does. Electroconvulsive therapy, ECT, involves inducing a brief, controlled seizure while the patient is under general anesthesia.
A seizure, that sounds scary.
It sounds scary, but modern ECT is very safe and controlled, and it remains one of the fastest, most effective treatments we have for severe, potentially life-threatening depression or mania, especially when rapid results are needed.
Okay, what about TMS?
Transcranial magnetic stimulation, TMS, is non-invasive. It uses focused magnetic pulses delivered from a coil placed on the scalp to stimulate specific brain regions involved in mood, usually parts of the prefrontal cortex.
And that's done while awake.
Completely awake, yeah. It's generally painless. Then there's vagus nerve stimulation, VNS.
VNS.
That one's a bit more invasive. It requires surgically implanting a small device like a pacemaker, usually in the chest. This device sends regular, mild electrical pulses to the vagus nerve in the neck.
And stimulating that nerve helps mood.
The vagus nerve is a major communication pathway to the brain. Stimulating it seems to help regulate mood and anxiety over the long term. It's typically used for very chronic, treatment-resistant depression or sometimes epilepsy.
Okay. One last critical piece in management. Dealing with other issues at the same time, especially substance misuse. If you have chronic mental illness and you're also misusing substances, that sounds like a disaster.
It really is. Addressing comorbidity, especially a dual diagnosis of mental illness and substance use disorder, is absolutely crucial.
Why is it so bad?
Substance misuse complicates everything. It can mask the underlying mental health symptoms, making diagnosis harder. It can directly interfere with how psychiatric medications work, making them less effective or even dangerous. And it dramatically increases the risk and severity of relapse for the mental illness.
So you have to treat both together.
You absolutely must. Effective treatment has to integrate specialized care for the substance use right alongside the management of the mental illness. Trying to fix one without fixing the other, it just doesn't work. It's like trying to patch only one hole in a sinking boat.
This next part feels really important. Taking that abstract idea of chronic and giving it real shape, because chronic doesn't mean the same thing for every condition, right? they follow different paths over a lifetime.
Exactly. The long-term trajectories can look quite distinct.
Let's start with maybe the most classic pattern, relapsing and remitting illnesses, like major depression or bipolar disorder.
Right. These are really defined by those distinct episodes. A period of intense illness, a deep depression, maybe a manic high, followed by a period where symptoms resolve almost or entirely. That's remission.
So it's cyclical.
Very cyclical.
Yeah.
Which really underscores why that long-term vigilance we talked about is so vital.
The sources mention something called the Kindling effect. What is that? It sounds concerning.
It is a significant concept. The Kindling effect is this idea, based on neurobiology, that once someone has had a few episodes, especially untreated ones, their brain becomes sort of sensitized or kindled.
Sensitize how?
It means that future episodes might need less of an external trigger, less stress, less disruption to actually start. The brain circuits are essentially primed for it.
Wow. So it gets easier to fall back into an episode.
It can, and often later episodes, if they occur, might be more severe, last longer, and become more difficult to treat effectively with standard approaches.
Okay, that really highlights the need to treat things early and consistently.
Absolutely. Understanding kindling strongly encourages jumping on symptoms immediately. Prevention, or early intervention, is usually much easier than pulling someone out of a deep established episode.
And this really points to why specialized long-term care is needed, especially for something like bipolar disorder.
Precisely. Bipolar disorder demands meticulous ongoing management. That almost always includes long-term use of mood-stabilizing medications. But specialized therapy is just as critical, particularly one called interpersonal and social rhythm therapy, or IPSRT.
Interpersonal and social rhythm therapy. What does that focus on? The rhythm part sounds interesting.
It focuses exactly on that, helping people stabilize their daily routines. Sleep-wake cycles, meal times, social activities, work schedules.
Why are rhythms so important for bipolar?
Because disruptions to those rhythms, things like shift work, jet lag from travel, even just staying up super late for intense social events can be major triggers for both manic and depressive episodes.
Wow.
So IPSRT helps patients track these rhythms rigorously, anticipate potentially disruptive events, and develop strategies to maintain regularity. It provides a predictable structure that supports the stability the medication aims for. It's about managing the environmental interaction with that chronic vulnerability.
That makes a lot of sense.
Yeah.
Okay, next trajectory. Anxiety disorders. These are described as having a wavy course. Not quite the distinct episodes of mood disorders.
That's a good way to put it. Anxiety disorders like generalized anxiety disorder, panic disorder, social anxiety, they tend to sort of ebb and flow in intensity, like a wave that gets bigger and smaller, but the water, the underlying anxiety, is always there.
So it never fully goes away into remission like depression might.
Often not completely, no. The core issue remains chronic, but the level of distress can vary hugely.
So when life's calm, maybe it's just background tension, manageable worry.
Right.
But then a big stressor hits, changing jobs, moving house, relationship conflict.
And the wave crests. It becomes acute, maybe overwhelming. Physical symptoms might flare up: muscle tension, headaches, stomach issues, sleep gets disrupted. Maybe the person starts using alcohol more to cope.
So the goal isn't necessarily to eliminate the anxiety completely.
Usually the goal is manageability, learning to ride the waves, developing sophisticated coping skills, deep breathing, mindfulness, maybe exposure therapy techniques so that even when the anxiety wave is high, you can stay functional and avoid making things worse, accepting the wave in a sense.
Okay, moving on to ADHD, which takes an adaptive course. The sources say symptoms often get better in adulthood, but rarely disappear entirely.
Correct. Those core symptoms of hyperactivity and major impulsivity often do lessen with age as the brain matures. But what frequently remains are what we call residual symptoms.
Residual symptoms, like what?
Things like chronic disorganization, difficulty with planning, prioritizing those executive functions, maybe being easily frustrated, losing things all the time, having trouble finishing tasks, or maybe being a very slow reader because it's hard to sustain focus on dense text.
And how does stress bring these out in adults?
Just like with anxiety, when stress levels go up or if the person lacks structure, those underlying residual ADHD symptoms become much more noticeable and problematic. A big deadline at work can suddenly make the procrastination and disorganization feel overwhelming.
So the adaptive part is key. How do adults adapt?
This is the crucial strategy. The adult learns, often through trial and error or therapy, to adapt their life around these chronic weaknesses. It requires real self-awareness.
Can you give some practical examples?
Sure. Someone might realize they're just terrible at managing detailed paperwork or finances, so they might choose a career path that plays to their strengths, maybe creativity or hyper-focus and short bursts, and then they actively delegate or get help with the administrative stuff. Maybe a spouse handles bills, or they hire an assistant if possible.
Using external systems.
Exactly. They create robust external systems, lots of reminders, visual checklists, strict routines for certain things to compensate for the internal executive function challenges. It's about consciously structuring their environment to minimize the impact of their weaknesses, freeing up energy to focus on their strengths. It's an ongoing, active process.
Fascinating. Okay, finally, the trajectory for schizophrenia described as a stepwise decline. Honestly, that sounds quite grim.
It does sound grim, but the sources offer important context that actually provides a lot more hope than that phrase suggests.
Yeah.
It's a very serious, complex illness, absolutely. But the stepwise decline model means the typical course is not a steady, continuous slide downhill.
It's not. How does it work then?
Instead, it's often characterized by long periods of relative stability called plateaus, which are then punctuated by distinct steps downward.
Plateaus and steps. Explain that.
So, the illness symptoms might fully manifest, maybe in late adolescence or early adulthood. The person receives treatment, gets stabilized on medication and with support, and they might reach a certain level of functioning, a plateau, and stay there, relatively stable, for years, sometimes many years.
Okay, that's the plateau. What's the step?
A step downward is when there's an acute worsening of symptoms, often leading to a new, slightly lower baseline of functioning. This decline might particularly affect cognitive abilities, things like working memory or complex problem solving.
That still sounds difficult.
It is difficult, but the crucial good news here is the potential length of the plateaus. With consistent, aggressive treatment, medication adherence is key. Therapy, support systems, the time between those steps can be very long. We're talking years, sometimes even decades.
So there can be long stretches of stability in functioning life.
Absolutely. That stability during the plateau allows for meaningful work, relationships, engagement in life. Understanding this pattern really emphasizes that every single day of sticking with treatment is a day spent potentially extending that stable plateau. It reframes adherence as actively maintaining quality of life. #tag7. Lifestyle, support, and empowerment.
Okay, we've got the chronic nature, the personalized treatments, the different long-term paths. Now let's get really practical. What can listeners actively do, starting today, to build on their professional treatment and maximize that time in remission, or on those stable plateaus?
This is where we really need to think about treating the whole person, not just the diagnosis label. And that brings us to lifestyle medicine.
Lifestyle medicine, what does that entail?
It's about creating a comprehensive plan that considers everything: nutrition, sleep, physical activity, stress management, even genetics and environment, all tailored to the individual. It aims to look for root causes and vulnerabilities, not just mask symptoms.
What kind of root causes are we talking about beyond the genetics and life experiences we covered?
Well, things like chronic inflammation throughout the body, which we now know is strongly linked to depression. Undiagnosed sleep disorders, like sleep apnea, which can wreck mood and thinking. Gut health issues, like we touched on earlier. Addressing these underlying physical factors can significantly improve the brain's ability to cope with its chronic condition.
Stabilizing the foundation helps the brain manage better.
Precisely. It's all interconnected.
So what are the absolute must-do, non-negotiable home remedies or lifestyle factors that support clinical treatment?
Number 1, without question, stick rigorously to the professional treatment plan. That means taking medication as prescribed, consistently attending therapy appointments. Don't stop just because you feel better.
That seems to be a recurring warning.
It's probably the most common reason for relapse, especially rapid relapse. And subsequent episodes can be harder to treat, so adherence is paramount.
Okay, what's number 2?
Number 2, avoid alcohol and recreational drugs. Period.
Why are they so detrimental?
They are destabilizing agents. They directly interfere with how psychiatric medications work, sometimes making them ineffective, sometimes dangerously amplifying side effects. They mess up sleep patterns. They can directly trigger mood episodes, especially mania and bipolar disorder. They just sabotage recovery efforts.
Got it. Avoid them. What about the basics like activity and sleep?
Hugely important. They are powerful medicine in their own right. Stay active. Regular physical activity is proven to help manage depression symptoms, reduce stress and anxiety. Plus, it helps counteract some common side effects of meds like weight gain or metabolic changes.
And sleep.
Crucial. Make healthy choices around sleep. Aim for sufficient, consistent sleep. A regular sleep schedule supports mood stability. Same goes for diet. A balanced, whole foods diet provides the nutrients the brain needs. Predictable, healthy inputs support stability.
Makes sense. Beyond what the individual does for themselves, what about external support? How vital is connection?
Support networks are absolutely non-negotiable for long-term success. This means leaning on trusted family, friends, partners, but also structured support groups can be invaluable.
Why are they so important?
They provide emotional understanding from people who get it. They offer accountability checking in, encouraging adherence, and maybe most importantly, they combat isolation. Isolation is both a risk factor for mental illness and often a symptom of it. Connection breaks that cycle.
And for the individual themselves, it's not just about taking meds, it's about actively coping.
Absolutely. You have to proactively develop strong coping mechanisms. This means becoming an expert on your own condition.
How do you do that?
Learn everything you can about your specific illness. Understand your personal triggers, what tends to make symptoms worse. Keep a journal to track moods, symptoms, potential triggers. Utilize resources organizations like NAMI, the National Alliance on Mental Illness, have fantastic educational materials and support groups. Practice stress reduction techniques that work for you. Mindfulness, deep breathing, yoga, whatever it is.
Knowledge is power, basically.
It truly is. The more you understand your chronic condition, the less frightening it feels, and the more control you have over managing its impact on your life. And maybe adopt a positive, hopeful, but realistic attitude.
Okay. One last really critical piece of advice that came up in the sources. Making big decisions when unwell.
Yes. This is a golden rule. Never make major, irreversible life decisions when your symptoms are severe.
Why not?
Because if you're in a deep depression or experiencing mania or severe anxiety, your thinking and judgment are likely impaired. Your perspective is skewed by the illness.
So decisions made then might be regretted later.
Often, yes. Huge decisions, quitting a job impulsively, ending a significant relationship, making a massive financial commitment, these choices made during acute illness can have really negative long-term consequences that just make recovery harder. The advice is always, wait. Wait until you're stable again before making life-altering choices. Hashtag TACCHON8. Conclusion and final thought.
So wrapping this all up, it feels like the biggest takeaway is this shift in perspective. The journey through mental health recovery isn't about searching for a final cure that might never come.
Right.
Instead, mental disorders, while rarely cured, are overwhelmingly manageable. The focus shifts entirely from elimination to achieving that sustained remission, that recovery, living a full, meaningful life defined by stability and purpose, not by the absence of struggle.
And we have the tools to do that.
We really do. Incredibly effective, evidence-based tools, personalized medications, specialized therapies that equip people for life, and maybe most fundamentally, that commitment to active self-management and leaning on strong support systems.
And you're realizing this isn't a statement of defeat or limitation. It's actually incredibly empowering.
How so?
Well, knowing that, roughly 1 in 7 people worldwide lives with a mental disorder, that tells you are absolutely not alone in this. And understanding that consistency in management, sticking with the plan, yields huge results, like extending those stable plateaus we talked about. That gives you a clear blueprint for how to live proactively and successfully. Knowledge really is the foundation for building that stability.
That leads perfectly into our final thought for you, the listener. We spent some time talking about the adaptive course of ADHD, how successful adults don't magically erase their ADHD challenges.
No, they don't.
Instead, they acknowledge those weaknesses, those chronic difficulties, and they consciously, actively build their lives around them, focusing their energy on where they naturally excel.
It's a powerful strategy.
It really is. And it feels like a powerful metaphor for living well with almost any chronic limitation, doesn't it?
I think so. We invite you to maybe generalize that wisdom. We've established that managing a chronic condition takes constant awareness, vigilance, adaptation. So think about your own life for a moment. Is there a non-mental chronic limitation you live with?
Could be anything, right? A physical disability.
Yeah.
Maybe a deep-seated emotional sensitivity you've always had. Perhaps a recognized weakness in a skill that's important to you.
Something you've been fighting against, trying to hide, maybe trying desperately to cure or eliminate.
What might happen if, just as an experiment, you fully acknowledge that trait today? accepted it as part of your chronic reality.
Yeah.
And instead of battling it,
You consciously started to adapt your life around it, restructuring things, seeking support, focusing energy elsewhere to find a better, more functional baseline with that limitation rather than despite it.
that willingness to adapt rather than just eliminate. Maybe that's the true essence of long-term recovery and resilience, whatever the condition might be, something